Hi, everyone. I'd like to thank Kristen and Dr. Kate Menard for inviting me to talk with you all today about COVID-19 vaccination and pregnancy. This is obviously a topic of utmost importance in the state of North Carolina, as well as the entire country and world, in fact, currently. And I hope to be able to give you some background related to the rationale for recommendation for this vaccine and pregnancy. Just a couple of quick disclosures. I do work on this Merck CMV Vaccine Advisory Group. I am an up-to-date contributor. I also work on the ACOG SMFM COVID task forces, and I serve on the NIH COVID-19 treatment guidelines panel. Quickly, this is what the number of cases of COVID infection and pregnancy look like currently in the United States. You could see there was quite a large spike around the winter time. This is really exactly mimics what we're seeing here in North Carolina. And you can see we are headed back up. This does appear to be driven by the southern states, and in North Carolina we are, and especially in the last couple of weeks, really seeing that increase currently. I likely don't need to tell this audience this, but I will for emphasis and just to keep it in the back of your minds that COVID infection in pregnancy is very serious and associated with severe outcomes. We initially did not recognize the magnitude of increased risk that was associated with COVID in pregnancy, but these CDC data were analyzed and have held up now in other forums as well. So there is not only an increased risk of ICU admission. If you look over to the right, that 3.0 means a threefold increased risk of ICU admission. Similarly, nearly a threefold increased risk of mechanical ventilation, 2.5-fold increased risk of ECMO, and most unfortunately, a 70% increase in the risk of death when a pregnant person gets COVID infection compared to that of a non-pregnant reproductive age woman. So these are really significant increased risks of adverse outcome from COVID during pregnancy. And so that is clearly the problem. And in the US, we do have 3 novel vaccines that have received EUA and then subsequent for the Pfizer vaccine, full FDA approval. The mRNA vaccines are Pfizer and Moderna, and the adenoviral vector is Johnson & Johnson. Of note, pregnant people were excluded from the original trials. And in fact, the women of reproductive age that were in the trial were asked to use effective contraception, and they required a negative pregnancy test prior to vaccination. However, despite this criteria, some pregnant people did receive the vaccine inadvertently, and this information was available at the time of the EUA submission, and thankfully was reassuring enough for us to initially provide a recommendation to allow pregnant patients who would like to get the vaccine to receive it. And here is where we are at currently for vaccine uptake, and it's quite a unfortunate and sad state of affairs in that we are seeing that the percentage of pregnant people aged 18 to 49 who received at least 1 dose of a COVID vaccine during pregnancy, overall, you can see the number here is 23.9%. This is frankly abysmal. And is particularly paradoxical given the fact that we know the increased risk of COVID adverse outcomes in pregnancy, the fact that we are seeing these incredibly low vaccination rates. And so, of course, the question becomes why? The approach to vaccination has been hampered by a lack of data in pregnancy. Those of us who have been doing this for a while, we're clamoring over a year ago about the need for pregnant patients to be included in the vaccination studies. And that is what slowed the accumulation of safety data to be able to provide a full recommendation. But at this point, thankfully, ACOG, the Society for Maternal Fetal Medicine, and the CDC all now recommend the vaccine in pregnancy because of the accumulating data that we have been thankfully able to generate in the past 6 months. The uncertainty regarding the effect of COVID on the fetus, COVID vaccination on the fetus, has been compounded by the fact that this is a novel virus. Obviously, none of us knew what this virus was 2 years ago. And mRNA vaccines are the first type of this generation, the first generation type to actually get into circulation. And so that has fueled hesitancy in the general population, but particularly among pregnant populations. And so what can we say that can be reassuring? One is the efficacy of the mRNA vaccinations. This is just a quick reminder that many, many thousands of people were included in the original trials. And as you can see on the left panel, 95% efficacy in all subgroups in the Pfizer vaccine. And on the right panel, 94% efficacy across all subgroups in the Moderna vaccine. This was true early on, and even with the Delta variant, we are seeing still significant protection from these vaccines. It is not to this level, it's not the 94, 95% efficacy, but it is still far, far better than without a vaccine in terms of both prevention of disease. I want to be very clear about that. The vaccines still prevent disease, even disease from the Delta variant, and also severe disease and the risk of ICU admission and death. How do these mRNA vaccines work? So they basically contain an antigen that's encoded by mRNA and using viral and non-viral delivery systems. And they essentially work to stimulate the immune system. It's a synthetic vaccine, and so it's amenable to rapid production and amenable to a rapid response to newly emerging pathogens. This is, I want to be clear, fantastic that we are able to do this so quickly. And we aren't relegated to the old vaccine development systems of growing the vaccines in eggs as we used to need to do. So this allows us to scale up, or allows the companies to scale up and actually administer vaccine rapidly. And just this little schematic here on the bottom shows the mRNA going into the muscle and really what happens to it. Essentially, it creates a viral protein chain and then is shown to the immune system. That leads to both B cell, which is the antibody responses, and T cell responses. So it allows your immune system to attack the virus if exposed from multiple sources. And so there have been delays in the data, as I mentioned, in pregnancy and lactation. Some of the original concerns were, are these vaccines safe in pregnancy? There were no human or animal safety data that were published initially. There was a little bit of information from people who had been inadvertently vaccinated, but what we did know is these are not live vaccines, so we felt good about that right from the beginning in terms of providing this vaccine to pregnant patients. And it's degraded quickly, so that mRNA is broken down in the muscle cells quite quickly by normal cellular processes. So unlikely the actual vaccine could reach the uterus and or the fetus, but hopefully the antibodies can. There were some concerns about theoretical risks about if the vaccine were to cross the placenta, could it cause a fetal inflammatory response? There's no really significant biologic plausibility for this based on the rapid breakdown that is seen of mRNA vaccines. We do not think that there's any fetal inflammatory response or direct fetal exposure likely based on the mechanism of action. And similarly, low biologic plausibility for transfer of the vaccine itself through breast milk. Hopefully the antibodies do pass through, but not the vaccine. And so here is the safety data that started making us feel ready to recommend vaccine in pregnancy. This was CDC data that was published in the New England Journal in April. And essentially they took the V-Safe pregnancy registry, the folks who got vaccinated and reported that they were pregnancy and then agreed to report their data to the CDC. And essentially, if you look here on the right side of this table, it shows the incidence of these adverse events. And on the left side, it shows the published incidence, so what we would expect the rates to be. And as you can see, for miscarriage, stillbirth, preterm birth, small gestational age, congenital anomalies, and neonatal death, we saw no increased risk from any of these outcomes during pregnancy. And these were relatively limited outcome measures, so it made some folks still hesitate. It also was a relatively small N. The data was based on 724 live-born infants. And what we know is that this included no Johnson & Johnson and nearly all third trimester administrations from this data. So more data has continued to accumulate, thankfully, to augment this very reassuring data. Since that original article that was released in April, there was just a couple of weeks ago a preprint release from the CDC that showed over the course of pregnancy, no increased risk of miscarriage. And this is the risk of miscarriage at each individual week of gestation up till 20 weeks. And so you can see that the cumulative miscarriage risk over the course of 6 till 19 weeks was about 14%. This is very reassuring given the fact that we know that there is an increased risk that there is a baseline risk of miscarriage that is in the range of 15 to 25%. So a 14% miscarriage risk in this population is very reassuring. Further, we've had a number of reports that have published the fact that these vaccines do work and stimulate a robust antibody response in pregnant patients. There are a number of these. This happens to just be one of my favorites that I'm showing you today that was published in JAMA. The reason I particularly like this publication is that it shows multiple areas of the human immune response. So it shows antibodies, it shows neutralizing antibodies. So basically, are those antibodies there and also working? It shows system serology and cellular immune response. And essentially, these different panels represent each of those different elements of the immune response. And what these investigators were able to show that for both the Moderna and the Pfizer vaccines, that pregnant patients were able to demonstrate a robust immune response that was as good as non-pregnant, and in fact better than a natural infection after receiving the vaccine. This was both pregnant and lactating patients, and it was seen in all of the elements of the immune system that they studied. Similarly, here they demonstrate that there is passage of immunity, both from the mother to the cord blood, as well as mother to breast milk. So this specifically looked at antibody response. So both antibodies and neutralizing antibodies were transmitted to the fetus as well as the infant. So this in and of itself demonstrates not only that vaccines might be safe in pregnancy, but they could even potentially provide protection to the fetus as well as a neonate. There have been some certain bumps along the road. This is not specific to pregnancy, but does seem to primarily impact women of childbearing age. And there was after the J&J vaccine, an alert from the CDC that showed that there may be what was originally called a vaccine-induced thrombotic thrombocytopenia, which were the advector vaccines associated with thrombosis, thrombocytopenia, and evidence of heparin-induced thrombocytopenia by an ELISA test. These have been reported. They are quite rare. They are in the range of a few per million, and certainly way more rare than complications of COVID infection itself. So while the J&J vaccine has had these relative bumps along the road, it is certainly better to receive this vaccine than it is to risk getting COVID infection. Just important points for people who are taking care of people who may have gotten the J&J vaccine. If they do have any of these severe symptoms, it's very important that you advise them that they get evaluated immediately, and a consultation to a hematologist would be appropriate immediately. And the big take home for this is to avoid use of heparin until this syndrome, which is now called TTS, is ruled out or another plausible diagnosis has been made. So lots of reassuring data. The question then becomes, okay, we've now got recommendations from ACOG, SMFM, CDC that we should provide the vaccine to pregnant patients. We know that the disease is severe in pregnancy, and there is a lot of risk of not getting the vaccine and almost no risk of getting the vaccine. And so what's the hesitation? Why are pregnant individuals hesitant to uptake this vaccine? This is work that was done here at Duke by one of our medical students, in which she assessed people early on in the pandemic. This was actually before there was even a vaccine available, and asked them, if there were to be a COVID vaccine, how likely would you be to take it? And you can see that 2/3 of these people who agreed to participate in research said that they would not be willing to take a vaccine. And so we dug a little bit deeper into this and looked at the health belief model, which is a model that evaluates why people are willing or unwilling to uptake a health intervention, any kind of health intervention that is known to be beneficial. And there are really 4 main domains, and we use the flu vaccine and flu as the way that we assessed this. And it would be a similar thought for COVID, in that it behaves similarly to flu in pregnancy. The 4 main domains are perceived severity. How likely do I think, if I get this infection, if I were to get the infection, how severe is it going to be for me? Perceived susceptibility. How likely am I to get the infection? Am I likely to be able to avoid ever getting this infection? Perceived benefits of the intervention. Is it going to help me if I take this vaccine? Am I going to benefit from it? And perceived barriers. Is it hard for me to get the vaccine? Do I have enough information? Do I have misconceptions about the vaccine itself? And interestingly, we looked at this health belief model and COVID vaccine uptake, and found that each of the areas of the domains were significantly associated with willingness to get a vaccine. So as has been true with other health interventions, this health belief model can provide us a framework for thinking through, okay, if you are worried about the barriers to getting the vaccine, then you're not going to get it. If you think that you're not likely to get the infection, then you're not going to take this vaccine. And all of these elements were associated with the likelihood of COVID vaccine uptake. And I think it is important food for thought for us to think about how we can intervene in these areas and educate patients in a way that is meaningful to them to be able to proceed with improved vaccine uptake in this population. Interestingly, our hypothesis was actually that patients would be more hesitant to get the vaccine if they had a higher risk of medical mistrust or perceived racism in healthcare settings or barriers to healthcare utilization. Interestingly, in this cohort of patients, we did find that our Black patients were less likely to be willing to uptake vaccine, and we anticipated that these medical mistrust and perceived racism would drive their hesitancy more so than the health belief model. But in fact, it was not associated with a willingness to uptake the vaccine. Medical mistrust, perceived racism, and barriers were not different between people who were willing and unwilling to take the vaccine. So that was unexpected for us, and I think something that is important to take away, in that if we are going to focus on improving vaccine uptake, it may not be, the hesitancy may not be where we assume it is going to be, and it may be in other areas. What are our remaining unknowns? So there are published data that are pending, there are data that are pending publication on birth outcomes from the CDC following first and second trimester vaccination. I know that the CDC is working day and night to try and get this information out to the public and analyze the data as it comes in. Similarly, J&J vaccine outcomes are being collected by the CDC. There have been no safety signals as yet that they've been concerned about, but it has not been able to be analyzed and released as of yet. One of the questions that still remains is, while we know that antibody passage happens during pregnancy, and that's incredibly reassuring, does it actually correlate with newborn protection? If we can demonstrate that it actually that this vaccine during pregnancy actually protects the newborn from getting COVID, that would be another reason for moms to be willing to get this vaccine. Similarly for lactation. And then is there differential protection based on trimester of vaccination? So for people who've already been vaccinated, might we want to consider boosters during certain trimesters? And if there is a need for a booster, when would it be given? So in conclusion, probably the most important thing that we can do for improving vaccine uptake for pregnant individuals in North Carolina is to meet people where they are. Just start with understanding, try to figure out what is their hesitation, where is it coming from, how can we educate them to address their sense of perceived susceptibility, perceived severity, and barriers to uptake of the vaccine. Pregnant people and their fetuses deserve research to answer these unknowns. This keep calm and conduct trials is one of my favorite sayings, that I put it at the end of almost all talks that I give. We need more clinical trials in pregnancy. We need them earlier. This pandemic is far from over, and we need to, as a scientific community, commit to providing pregnant people and their fetuses research to be able to guide their decisions. We know that pregnant people are at increased risk for severe illness and death. If patients are unvaccinated, we should give any vaccine as soon as that patient is willing. We should make it as easy as possible for people to obtain the vaccine and not put barriers before them. This vaccine is a potentially life-saving intervention. I have spent far too much time taking care of pregnant patients with COVID on ventilators and delivering their babies prematurely. We really need to, as a scientific community, pull together and recommend vaccine to save the lives of our pregnant patients and their fetuses. So I thank you very much for your participation, and I hope that if there are any questions, that those of us in this field can go ahead and answer them for you. And please feel free to reach out.